Welcome everyone to Bone Voyage, a podcast dedicated to prevention and raising awareness of musculoskeletal disease. My name is Dr. Kranti Peddada, an orthopedic surgeon, bone and joint health advocate, and your host for this show. Come join me as we embark on this journey to better bone and joint health. Welcome everyone to another episode in our knee arthritis series. In the last episode, we talked about who's a good candidate for total knee replacement surgery and what surgery and the recovery process entail. In this episode, we will dive a little deeper into knee replacement surgery and discuss the recent role of technology, minimally invasive techniques, and less common surgical alternatives for knee arthritis. As always, please keep in mind that everything presented here is purely informational, should not be interpreted as medical advice, and does not create a doctor-patient relationship. Please consult a physician or another qualified healthcare provider with any questions you have regarding a medical condition and before you make any changes in your healthcare behavior. Everything I discuss is strictly the opinion of myself and does not reflect the views or position of any entity I represent. Please reference the episode description for a full disclaimer. With that, let's get right into it. Since the birth of modern-day total knee replacement surgery, we've been working to make the operation better on all fronts, design implants that last longer, increase precision, and enable faster recovery with less pain. Implant design has come a long way, and now most manufacturers have been using variations of the same basic design for the last 2 decades because it works well. One of the biggest changes in recent years has been the use of technology to improve the accuracy of implant placement. Studies have shown that positioning the implant outside of an accepted safe range can lead to early failure and necessitate revision surgery. Computer navigation was developed initially to minimize these outliers. The navigation system creates a 3D map of the knee and helps the surgeon determine where to position the cutting guides to accurately remove the cartilage and bone in the desired alignment. Robotic technology, which has gained popularity in the last decade, goes one step further. In addition to providing a 3D map for alignment, a robotic arm assists during surgery. In most robotic systems, the robotic arm carries a saw or a burr and makes the different bone cuts under the control of the surgeon. The robotic arm ensures the surgeon removes bone in the planned direction and does not overshoot or cause injury to surrounding structures. It's important to note that the robot is not autonomous. The navigation software provides data that helps the surgeon create a plan, and the robotic arm helps ensure accurate and safe execution of that plan by the surgeon. But the question is, does all this technology improve outcomes? Lots of studies have tried to answer this question by looking at a few different parameters. One is range of motion of the knee. Like we talked about in the last episode, stiffness is the most common complication and can occur in 5 to 10% of patients. While some studies suggest that patients can regain their range of motion a little faster with robotic surgery, there appears to be no difference in final range of motion after complete recovery. Pain also might be a little less early on with robotic surgery, but is comparable with manual techniques by 4 to 6 weeks. What we're quite sure about, though, is that by 6 to 12 months after surgery, there is no difference in how patients feel about their knee, whether it was done with robotic assistance or conventional methods. Improvements in pain and function, as well as range of motion, appear to be equal. While robotic surgery does confer more precision in alignment of implants and reduces the frequency of outliers, that increased precision has not been shown to translate to better outcomes overall. Surgeons have also been experimenting with different techniques of doing knee replacement surgery, specifically trying minimally invasive approaches. The tried and true method, which is still most used today, involves cutting the inner half of the quadriceps tendon to gain exposure to the knee and then repairing it back together once the surgery is completed. The quadriceps tendon connects your thigh muscles to your kneecap and provides the mechanism to straighten your knee, which is critical for walking, stair climbing, jumping, and general knee stability. Several minimally invasive approaches that have names like mid-vastus, sub-vastus, quad sparing, and direct lateral have been developed to spare some or all of the quadriceps tendon while maybe using a smaller incision. Studies have shown that these approaches may result in less pain, as well as improved range of motion and quadriceps muscle strength in the early postoperative period, particularly in the first week. The reduction in pain is small though, on average 1 or 2 points on a 10-point scale, and the final range of motion after full recovery is no different compared to the conventional approach. The drawback of these approaches is that they are more technically demanding and provide less visualization, which makes it more challenging in patients with severe arthritis and deformities. The bottom line is that technology and minimally invasive approaches may enable faster recovery for some patients, but do not improve long-term outcomes after total knee replacement surgery. You should select your surgeon based on their reputation and experience and your confidence and trust in them. The long-term outcome of your total knee replacement will likely depend more on these factors as opposed to any specific technology or novel way of doing surgery that is advertised. Now that you have a general overview of total knee replacement surgery, we're going to spend the rest of this episode talking about a few alternative surgical options for knee arthritis. The first is arthroscopic surgery. Arthroscopic surgery is a very common procedure performed for injuries inside the knee joint, such as ACL and meniscus tears. The surgery is done through 2 or 3 small incisions, and a camera is placed inside the joint for visualization. Specialized instruments are inserted through the small incisions to perform the operation, whether it's repairing a meniscus tear or reconstructing an ACL. A couple of decades ago, it was very common for people with arthritis to undergo what's called arthroscopic lavage and debridement, where you basically clean out the joint with arthroscopic tools. The procedure would involve flushing a lot of fluid through the knee to remove any inflammatory mediators, smoothing out the cartilage irregularities, and trimming away any meniscus tears. It was a minimally invasive alternative to help people buy more time before a knee replacement. However, studies have consistently shown that these clean-out procedures do not work. In fact, a study in 2002 helped prove this when they randomized people with arthritis to receive arthroscopic surgery and a sham surgery where incisions were made but no instruments were actually inserted. The patients and clinical staff were blinded to which surgery patients had. The study found that at follow-up points between 2 weeks and 2 years after surgery, outcomes of pain and function were no different between the arthroscopic and sham surgery groups. Therefore, we no longer perform arthroscopic surgery as a primary treatment for knee arthritis. The next 2 surgeries we will talk about apply to patients with arthritis isolated to a single part of the knee. We artificially divide the knee into 3 compartments: the medial compartment, which is the inner half, the lateral compartment, which is the outer half, and the patellofemoral compartment, which is the area underneath the kneecap. Some patients may predominantly have arthritis in a single compartment of the knee, and the most common compartment affected is the medial compartment. The first surgery is called a high tibial osteotomy, or HTO for short. This procedure involves changing the alignment of the knee by creating a wedge in the shin bone or tibia. The new alignment offloads the compartment of the knee that's arthritic, so when you walk and bear weight, less load goes through the affected part of the knee. The surgery is only applicable for medial or lateral compartment arthritis and not patellofemoral arthritis. The concept of an HTO is very similar to the offloader brace we discussed in episode 3, except an HTO creates a permanent change to knee alignment through surgery. Unlike a knee replacement, an HTO preserves your native knee joint. This can be very advantageous for young, active individuals, typically younger than 50, who may otherwise wear out a knee replacement from consistent high-impact activity. Eventually, the arthritis can progress and may necessitate a knee replacement surgery, but HTOs are very effective in delaying this. Studies show that even 10 years after HTO surgery, 50 to 85% don't need to have a knee replacement. The second surgical option for arthritis in a single compartment of the knee is a partial knee replacement. Partial knee replacements can be performed for the medial compartment, lateral compartment, and patellofemoral compartment. The surgery is also called a unicompartmental knee arthroplasty as opposed to total knee arthroplasty. Partial knee replacements have the advantage of being a quicker operation with faster recovery, and patients report less pain, have fewer complications, and experience greater range of motion of the knee compared to a total knee replacement. This makes sense because the remaining 2/3 of the knee is left intact. The other advantage of a partial knee replacement is that patients report the knee feels more natural. This is because all the stabilizing ligaments of the knee are left intact in a partial knee replacement. A total knee replacement involves removing at least the ACL and sometimes the PCL to make room for the implant. This changes the normal kinematics of the knee, and some people can be more sensitive to this change than others. The drawback to partial knee replacements is that they wear out slightly faster and arthritis may eventually progress in the other compartments of the knee, both of which may necessitate conversion to a total knee replacement. Nonetheless, partial knee replacements are still quite durable, with studies showing that 90% can last 10 to 15 years. Let's recap what we talked about in this episode. Robotic technology is becoming more popular in total knee replacement surgery. The technology provides 3D navigation and a robotic arm to ensure accurate and precise implant positioning. Minimally invasive techniques offer an alternative way of doing knee replacement surgery by sparing the quadriceps tendon. While robotic technology and minimally invasive surgery may offer slightly faster recovery, reduced pain, and improved range of motion in the early postoperative period, the final outcomes and patient satisfaction after full recovery are no different compared to conventional total knee replacement surgery techniques. For people who have isolated arthritis in one compartment of the knee, two alternatives to total knee replacement surgery can be considered. A high tibial osteotomy is favored for young, active individuals who might wear out a knee replacement quickly. A partial knee replacement offers the advantage of faster recovery, better range of motion, and a more natural feeling knee, but the drawback is that it's less durable than a total knee replacement and opens the possibility of arthritis developing in the other parts of the knee. Both HTOs and partial knee replacements may eventually need to be converted to a total knee replacement. One surgery that does not have a role in knee arthritis treatment is an arthroscopic cleanout procedure. In the next and final episode in our knee arthritis series, we will summarize key points from earlier episodes and put together all the concepts we have talked about. I wish bon voyage to all of you on your journey to better bone and joint health. See you next time.
Thank you for tuning in to this episode of Bon Voyage, your journey to better bone and joint health. Please join us on Wednesdays for new episodes. If there are certain topics you would like to listen to, or if you have feedback for the show, please email us at bonvoyagehealth@gmail.com. If you enjoy listening, please follow and subscribe to our podcast. Thank you for all your support.